Fantastic. All right. Well,
Thanks, Corey.
first of all, thank you for inviting me. I don't always get the chance to listen to myself speak for a while, but it'll be fun for me. My name's Paul Lezberg. I'm the product director for the OCS Heart, which is the TransMedics platform for ex-vivo heart preservation. What I'd like to do is talk to you a little bit, very, very quickly about myself, but more importantly, a tiny bit about the company, a little bit about the problem of organ shortage, which you're all intimately involved in and knowledgeable in, and then talk a little bit about OCS kind of basic theory, as well as the initiatives that we have for DCD heart preservation. So, I've been with TransMedics for just about 16 years. It's 16 years at the end of the month. And my major role is user contact. I'm responsible for deploying devices to new centers. I'm responsible for their training, for a program of 24-hour-a-day, 7-day-a-week telephone support, and really, answering all the nuts and bolts clinically, either before, during, or after an OCS case, so that our users become competent and comfortable with the technology and can better serve patients. The TransMedics is located in Andover, Massachusetts, so around 30 miles north of Boston. We currently have 3 organ platforms, all ex-vivo perfusion systems for lung, heart, and liver transplantation. You're all aware very well, I'm sure, of the shortage of organs. And when we're thinking about the thoracic space, lungs and hearts, we know that somewhere in the range of 3 organs out of every 10 are used for transplantation. We also know that under the current conditions of standard procurement and preservation on ice, there's somewhere in the range of 30 to 35% post-transplant complications. Again, spread between lung and heart, and also varying quite a lot between institutions. Some of this may be related to the different types of organs that are most available in a particular region. But the fundamental issues, the concerns with cold storage, number one, ischemia, cold ischemia. And we all know the rule of thumb that typically once you start getting past 4 hours or so of cold preservation, the possibility of graft dysfunction, the possibility of a lower survival rate increases, particularly when you start adding in the age of the donor. As they get older and additional ischemic time is added in, the survival statistics begin to diminish, PGD begins to increase. In the cold box of ice, you really have no idea, no opportunity to optimize the condition of the organ. So it's basically considered kind of a black box. You see an organ functioning in a donor, you preserve it on ice, you expect that organ will work equally as well in your patient. But in the middle, there's nothing that you can really do to impact that. And you have no real ability to see how that organ may be performing by the end. TransMedics kind of becomes, or our platforms kind of become a link, a missing link, or replacing a missing link between all of the advancements that have been made in transplant science, if you will. There have been great leaps in medical management of both donors and recipients, really. Advances in mechanical circulatory support have given patients a lot longer life and a lot longer runway to transplantation. Things like dealing with renal dialysis and so on all improve some of the odds. On the other side, post-transplant, surgical techniques have improved. anesthesia and care, post-operative care, and immunosuppressives, of course, have made a great influence. But for around 40 years, there's the piece in the middle. The organ preservation really hasn't changed from static cold storage, maybe fussing around a little bit with the storage solutions. So our platforms represent that middle piece. How can we improve the viability of organs? How can we make more organs available for transplantation? And so, as I mentioned earlier, we have a platform for lung, which is approved in the United States for a couple of indications, which does include or do include DCD. We have the heart platform in the middle of the slide. This has been available in Europe since 2006 when it was CE marked. We've completed several studies, the PROCEED 2 study, which looked at standard of care, kind of standard donors, standard patients, and it was a randomized comparison between standard of care preservation or cold static storage and OCS. We have also completed what we call the EXPAND Heart study, which was a study of higher risk or extended criteria donors. Those donors were part of a menu, if you will, that involved anticipated longer procurement times or cross-clamp times, hearts of older age donors, greater than 55 years, hearts with left ventricular hypertrophy, with some non-specific coronary artery disease, history of diabetes, history of alcoholism. And so, a lot of these hearts had single criteria enrollment, but many had multiple criteria: older age plus longer distance, left ventricular hypertrophy plus cardiac downtime exceeding 20 minutes. So they were a more complex donor than what many institutions would use on a daily basis. We've had an ongoing study of the EXPAND Continued Access Program, while the EXPAND program, the original 75 patients, are under review by FDA for hopeful approval early next year. And then what we're really talking about today is the DCD. So the DCD procurement using OCS started around 5 years ago in Sydney, Australia, and then was really aggressively picked up by multiple centers in the United Kingdom, the leading institution being Papworth Hospital, which is in the Cambridge region of the UK. And outside the United States, there's been more than 150 DCD transplants. Again, between the Sydney group and multiple now UK groups. And then we've recently completed our first DCD study of 90 DCD transplanted patients. And we are just in the tail end of finishing off 90 standard of care patients. So this was a randomized study. It's the last enrollment of a DCD was the last day of September. And some of your colleagues have probably not only heard about this study, but may very well have seen some of these procurements, at least on the donor OR side. We are just about to start enrolling in our DCD CAP, or Continued Access Program, for DCD hearts. This will be a single arm study, just DCDs, another 90 patients. And like the first study, there'll be up to 25 participating institutions across the country. And I'll show you a map in a little bit that kind of shows the location of a lot of these groups. And then finally, we have our OCS liver platform on the very right of this slide. So fundamentally, as I mentioned earlier, one of the big differences between ex vivo warm blood perfusion is that whole ischemic period. It's the duration of ischemia. And although this slide that you're looking at has a lung donor and a lung recipient, the concepts are always the same. In a cold static storage, you've got procurement of the organ from the donor, immersion in a cold solution, a preservation solution on ice, and then your transport back to the recipient hospital. And when ready, that organ can be transplanted. So literally in a 4-hour, if you had a 4-hour travel time, you'd have something like a 4.5-hour ischemic period from donor clamp to delivery at your OR, and then you've got your implant time. With the organ care system, any of our platforms, we're reducing the ischemic window. So at the very beginning in the donor hospital, from the time of cross clamp in the donor until the start of warm blood perfusion is somewhere in the range of 30 minutes. In our EXPAND study of 75 patients, and probably similarly in the DCD, although we've not finished all the math, it's about 31 minutes of cold ischemic time at the beginning of the case. Then you've got warm blood perfusion with a short period still in the donor hospital while you take a few samples to establish the optimization of perfusion. You've got transportation back to the recipient hospital. And then when the implanting surgeons are ready, you can cool the heart mechanically on our system by connecting to a standard OR heater cooler, and then arrest the heart with a small volume of cold cardioplegia. And so then the rest of your ischemic time is the cold implant time. So starting your anastomoses in your recipient until the release of the recipient cross clamp. And with OCS Heart, that's generally the end of warm perfusion until the removal of the recipient cross clamp is a mean of around 70 minutes, remembering that most of that time is your standard OR implantation time and has nothing to do with OCS. So here's a map. It shows you where we are internationally, but if you look at the top left, the North American map, you'll see that we've got institutions throughout the United States working with heart, lung, liver. There are a few groups that are working with all three platforms actually. And in the United States right now, we have 26 or 27 OCS Heart centers. In terms of numbers, we're well over 1,500 transplants across all three platforms. The heart being the first system, we're actually about in the range of 1,000 OCS hearts transplanted to date, with more than 200 of those being DCD. There's about 150, 160 outside the US. And as I mentioned, there are about 90 so far inside the United States. If you haven't seen the system yet or don't know anything about it, essentially what we're doing with the OCS Heart platform is recovering the organ from the donor, cannulating it, which I'll show you in a few moments, so that you've got both inflow and outflow of perfusate from that heart, and then putting it in a near physiologic state. So the heart will be beating, but it will not be loaded. In fact, more often than not, because lungs are often taken, you're left with no full left atrium. You're only left with a left atrial cuff. So it's a beating heart, it's being perfused, but it's not actually loaded or doing work. And some of the other near physiologic items relate to the chemistry that is optimal for the organ in the ex-vivo platform and so on. The system is about the size of a small copying machine. And in a later picture, you'll be able to get the relationship of a person standing next to OCS. does give you the ability to resuscitate the donor organ from the insult of brain death, circulatory death as well. Gives you some opportunity to assess the organ both functionally and metabolically. We rely on lactate concentration of the perfusate entering the heart. So the lactate in warm, oxygenated, nutrient-enriched blood entering the heart to perfuse the muscle versus the lactate levels in the outgoing flow from the heart, the deoxygenated perfusate. And so it's a relative value between arterial and venous lactates and the overall trend of lactate over time that helps us understand metabolically how well we're perfusing and preserving that organ. Functionally, you do have the ability to do angiograms on the system. You have the ability to do an echo, though some of the images aren't quite physiologic, this being an ex-vivo platform. And then on the bottom bullet, as I've already spent a little time in a previous slide, you expect to have a significant reduction of ischemic time. In our EXPAND trial, we had I believe, 382-minute mean cross-clamp to cross-clamp, but 102-minute mean of ischemic time. That was the cold, non-perfused periods, around 30 minutes before perfusion and about 70 minutes after. That is the total ischemic window. Here is the platform. The second image from the left is the console. So that's your reusable hardware. And within it, you've got batteries so that you can run either on AC power or battery during transport. You've got a gas bottle that's good for around 35 or 40 hours of preservation time. On the left-hand side of that console, there's a rectangular box with kind of a gray face and 3 brassy-looking circles on top. That's a 3-channel infusion pump so that we can deliver necessary medications and hormones and substrate to the organ throughout preservation. The top left image is our wireless monitor. So in terms of transportation, you want to be able to manage and monitor what's happening on the system while sitting in your seat. So the OCS console can be anywhere in the plane or in the ambulance or in a helicopter, and you can be sitting in your seat with that Bluetooth-enabled monitor on your lap, and you can monitor and manage and control what's happening to that organ. To the right of the console is the heart perfusion module. This is a single-use, sterile, disposable item. It is fully calibrated, fully set up. All you have to do is drop this into the console, connect a couple of probes, and you're ready to go. It literally takes about 5 minutes from the time you start opening the box to have the module fully installed in the system. So very, very quick. And then most to the right is our heart solution set. You can kind of see probably that there are 3 bags or 3 chambers in this set. Each one of these chambers is 500 milliliters of solution. They're all aqueous based. The one on the left is what we call priming solution. And it's just an aqueous solution with some mannitol, some electrolytes, and some buffer. And that 500 milliliters, along with some donor blood, is base perfusate for OCS preservation. The 2 chambers to the right, or the middle one and the right one, are mixed, joined, if you will, just before use. And within those combined chambers, you have glucose as a substrate, some electrolytes, some amino acids, and importantly, for the management of perfusion of the organ, you have adenosine. We have a dilator on board to help enable or restrict dilation of the vasculature of that organ in order to optimize perfusion. A few other things that you would see with the procuring team: they'll have a run bag with some extra supplies and things. In the middle of your screen, you'll see a defibrillator. So some hearts, once they are connected to the system and you begin to perfuse them and warm them, they'll begin to beat on their own. But quite a few hearts will need a defibrillating shock just to get going. So we have electrode pads integrated into the perfusion module, into the organ chamber, that allow us to connect a defibrillator externally and then deliver a shock through those pads. So you're not using paddles, you're using some stainless pads that are pressed up against the myocardium. Once the heart starts beating, you won't have to defibrillate again. This is, blood chemistry and normal electrical conduction of the heart takes over. And then finally on the right, again, if you're in the operating room, you're probably going to see either an iStat portable gas analyzer, such as the one on the screen, or the competing product, which is Epoch, is another handheld analyzer. From our standpoint, we couldn't care less what the team uses, but from shortly after beginning of perfusion until shortly before cooling and removing the organ from the device, the retrieving team will take these lactate determinations throughout perfusion to help them understand how well the organ is being preserved. The basic flow pattern, if we start kind of at towards the lower left, maybe the 8 o'clock position, you've got the reservoir. In the reservoir, you're starting with some donor blood and that priming solution that I described earlier, and some medications. And then going counterclockwise, you've got pulsatile flow of that perfusate through an oxygenator or gas exchanger. You see the pattern goes up to the top, takes a left, that perfusate is warmed, and then as you continue in the counterclockwise mode, you'll see that the arrow points to the aorta. So the aorta is cannulated just before the start of perfusion, and that really becomes the incoming plumbing for warm, oxygenated, nutrient-rich perfusate. That perfusate is used to oxygenate the tissue, the myocardium itself, feed it, and then you have venous drainage from the coronary sinus out a PA cannula that's also been sewn in to the pulmonary artery, and that outflow returns to the reservoir. So it is a closed loop in terms of fluid circulation. It is, however, open. There's some venting, sterile venting to the environment. So it's not a pressurized system, but you do have a continuous flow pattern of perfusate. The wireless monitor displays a number of different fields. Along the left-hand side, you'll see the kind of physiologic panels. So we look at coronary flow, aortic flow, which is the total pump flow, if you will, saturation, hematocrit, the temperature of the perfusate, which we happen to run at 34 degrees, so a few degrees shy of physiologic temperature. And we do this to give the heart just a little bit lower metabolic demand. It's basically allowing it to rest a little bit during this process of removing from the host and bringing it over to the patient. On the graphical piece, the bottom frames across the bottom there, one is showing you circulation of the pump, is the presence of a data card, the status of our gas, the OCS batteries, and in this particular case, there's 7 hours and 45 minutes of remaining runtime. A total 3-pack of these rechargeable batteries gets you around 8 hours or so of runtime. So it's typically not necessary to plug into power during transportation. To the right of that panel is the battery associated with the monitor itself. And then you've got kind of three horizontal bars, A, B, and C. Those are the three channels of our infusion port. And then finally, the Bluetooth tower that I'm sure you all recognize. The primary fields of the monitor have three graphics. On the top graphic, this is kind of an elongated rectangle. You'll have your aortic pressure, systolic, diastolic, and mean. In the next graphic down, we typically display heart rate, but this is not a diagnostic EKG. We're really just capturing R waves. And then finally, in this bottom graphic, what we like to do is display the trends of coronary flow and aortic pressure. And then we plot the lactate samples into the monitor. So these red and blue bars that you see represent red arterial lactate values and blue venous lactate values. You can see in this first pair, the venous is higher than the arterial. The blue is higher than the red. That's a sign of inadequate or suboptimal perfusion. Then you see that the overall trend is downward and that the venous values are a little bit lower, or the blue bars are lower than the red bars. That's a sign of good perfusion. That's a sign that the heart is actually consuming lactate, where this is a sign, this first pair, that the heart is secreting lactate. Okay, so we're using the relationship of arterial and venous at a point in time, as well as the overall trend of lactate to help us understand adequacy of perfusion. So in practice, what would you see in the donor OR? Specific to the DCD, we provide a rather large venous cannula. For brain dead donation, we typically say you can insert that cannula into the superior vena cava. For a DCD donor, where circulation has stopped, where the right atrium is probably quite full, as a result, we tell the surgeon to place the cannula in the right atrium. You'll get a quick blood collection, and it allows the right atrium to decompress, which can only be good. The blood collection process, it's one that certainly all of the abdominal teams are quite interested in. Generally, it takes about 60 to 90 seconds to collect somewhere in the range of 12 to 1,500 milliliters of donor blood. The minimum value that we like to collect is 1,100. 1,200 or a little bit more is better. We had some challenges by some liver teams, asking the question about how does this collection process work? How fast is it? Is it going to interfere or render my organs less viable later? And we looked at the math. We looked at the first, I think, 70 or 75 procurements, DCD procurements that we had in our DCD study. We found that indeed this general range of about a minute or a minute and a half or 2 minutes seems to be quite accurate, because from the time of the start of donor incision until the time of the beginning of perfusion with cold cardioplegia was about 4 minutes mean. So if you account for skin incision, sternotomy, inserting the cannulas for perfusion, and you give that, say, around a 2 minute-ish average, it's taking somewhere in the range of 1 minute, 2 minutes to collect the blood and start perfusion of the organ with the cold cardioplegia. So it is a little bit of an anxious time for the liver surgeons, but we really don't appear to be adding a whole lot of time to the process. The answer to the question that many people have is, Why not just add packed red blood cells from the blood bank instead of donor blood? And the problem with that is that the preservatives that are used in banked products would impact the chemistry of the perfusate and potentially make the heart not begin to reanimate, because there's a lot of potassium, a lot of sodium, EDTA, and so on. So the only real way to do that is to wash packed cells first, retreat to balance some of the chemistries, and go from there. So we're still proponents right now of blood collection. If you participated or heard of procurement using OCS, then you may know that we like to have a donor hematocrit in the range of 25% or greater. That just helps with overall oxygenation of the organ. We were a little bit concerned in the beginning of the DCD trial whether or not most OPOs would allow the donors to be heparinized or not. It turns out that most have allowed donor heparinization. But despite that, through our history, we've always recommended adding additional heparin to our blood collection bag. So in the case of a brain dead donor, we typically say add 10,000 units of heparin to our blood bag. In the case of a DCD, we suggest adding up to 30,000 extra units of heparin to the blood bag. And so the process is try to optimize the donor best you can, collect the blood, and then cross clamp and flush with cold cardioplegia. The image that you see on this slide is a person holding the collected blood in the bag and then transferring that blood through a leukocyte depleting filter into the reservoir. And so if you were just 30 seconds further into this action, you'd actually start seeing blood being delivered into the reservoir here. Once the donor organ is recovered from the donor, it is cannulated. So the superior vena cava is oversewn usually early. And then the aorta is trimmed. And then 4 double-sided hard pledgets are placed at that distal end of the aorta. One of our aortic cannula tips is inserted into the aorta. And then using the sutures from the pledgets, you pull up so that the tissue of the aorta comes up to the stops all around this cannula. And then just a cable tie is placed around the aorta below the pledgets and above the ridge on the cannula. First hand tightened, and then we provide a cable tightening or tensioning tool that allows the surgeon to snug up that cable tie and then cut off the tail hair. So that's your aortic cannula, which is really the securing cannula and represents the inflow pathway of perfusate to the organ. The second cannulation is for the pulmonary artery. So this is where you're draining perfusate that's passed through the heart back into the reservoir. When we assume that lungs are being taken, we assume that there's a short pulmonary artery. So the surgeon would start with a purse string suture, insert our cannula, tie off their purse string, and then just take a piece of umbilical tape that we provide and snug that up around here as well, just to make sure there's no leaks. Kind of an unusual situation for the surgeon is that they're going to be placing the heart in the organ chamber with the posterior facing them. So instead of seeing the anterior portion of the donor heart, they're actually looking at the back. And although this is a porcine heart, this is what you would see. So there is your beating heart. At the top, we have our aortic cannula and our aortic connection. This is the pulmonary artery cannula that exits the PA and connects to the bottom right drainage port of the organ chamber. And then this is a vent line that we've placed in the left atrium through the valve and into the left ventricle to decompress and to allow any blood and perfusate that might contain air from entering the aorta when the left side contracts. Okay, so right heart is on the right, left heart is on the left. It's a pretty interesting looking object if you've never seen it before. This gives you a little bit of understanding of size relationship, less than 100 pounds. So typically carried, when you're moving off the mobile base into a vehicle, it's very easy for two people to lift the system into the back of an SUV, into an airplane. It's been plenty of times in helicopters and so on. In fact, the very first case that we did, we took a ferry from, I think it was Portsmouth in the UK to the Isle of Wight and back. So that was fun. And the group in Kazakhstan and Astana have actually taken the OCS on a public train. So I talked to you a little bit about the trial that was just concluded, and that was our first DCD heart trial. And the purpose was to assess the effectiveness of the OCS in preserving and assessing DCD hearts. It was a randomized study, so there was a 90-patient DCD arm compared to 90 patients transplanted with hearts on ice. We activated 25 sites in the study, but unfortunately, COVID rendered something like half of those unable to actually reach enrollment before it ended. It was rather interesting to us. We came into the study thinking that the US surgeons would be more conservative than abroad. We expected that the first 50 or so patients could take 2 years. And it turned out that it took 10 months on the nose to transplant 90 DCD hearts in the United States. So it was a very, very exciting trial. There's an awful lot of interest in it. We're very, very happy with the enthusiasm. We're happy with the outcomes. And it's too late really to discuss what we found, but we had a very high yield. We had 89% of the hearts put on the OCS were used, with very, very good outcomes that we'll be able to discuss sometime next year once all the data has been collected and validated and so on. One of the unique features of this study, at least for us, is that because we had a number of new centers that had never used our technology, and because in the United States, the DCD recovery was going to be quite novel in terms of heart recovery, we did build into the protocol 2 mandatory training runs by each group. So these would be donor hearts that were never, ever going to be transplanted. This was an opportunity for the teams to work through that very rapid period from withdrawal of care to skin incision, recovery of the organ, perfusion, and so on. It was an opportunity to sharpen their skills on organ management and work out any kinks in the process that might adversely affect the organs or the team's performance at a later date. These have turned out to be extremely helpful, though in fact a little bit challenging in terms of the other organ recovery teams, and fairly so. There were a few instances where other teams' wishes trumped the heart team's wishes, because these hearts were never going to be transplanted and the other organs were. But by and large, it was a very, very successful experience, and we're very excited that how well it went and how everybody performed. There were very few limitations to recipient eligibility. They had to be listed candidates. They had to be 18 years of age or older, and had to have provided consent for use of their information. The only patients that were excluded were those that had previous transplants, including bone marrow, those who had chronic use of hemodialysis for chronic renal failure. We did not allow multi-organ transplants in that study, though there were a couple done on a compassionate use basis outside of the trial. And then, of course, an investigator could decide that this was not a good patient for this study. On the donor side, this is something that I think you probably find interesting. This was our definition of warm ischemic time. And it is considered, if you read the papers put out by the groups in Australia or the UK, they consider a functional warm ischemic time. So it really isn't about the time of withdrawal of care. It's about triggering the start of malperfusion. And so one criteria was when the systolic blood pressure fell below 50 millimeters. The other criteria was when saturation fell below 70%. And as long as one or the other or both of those was sustained for at least 5 minutes, that was the beginning of our warm ischemic time. The end of the warm ischemic time was the beginning of administration of cold cardioplegia to arrest the organ. The exclusions, we didn't want a donor heart with previous cardiac surgeries, known coronary artery disease, myocardial infarct, and so on. And then finally, in the set, how did you decide to accept or not accept a heart that had been perfused on the system? So for accepting a heart, as I mentioned earlier, it's largely about developing or establishing a stable or downward trending lactate trend and maintaining certain perfusion parameters within historically normal ranges. For pressure, mean aortic pressure, the range being between 40 and 100 millimeters, so a very wide range. And then on the other hand, a surgeon could reject a heart based on not being able to establish a good lactate picture, or just looking at it and not thinking that there's good performance of that heart. Maybe it's not contracting well, maybe it's dilated, or anything else that surgeon deems concerning. They could turn down that heart, and that organ was then sent to a core pathology lab to look for any previous pathological history that might have resulted in that turn down. As I mentioned, the next step for us is initiating enrollment in our continued access program for the DCD study. We do have an approved protocol, and we're just going through the steps with the centers to get everybody activated for that. So by the end of the year, sometime in December, most likely, you would begin to hear of new enrollments in one of our studies. So that's what I put together for you today. I think we have a little bit more time for questions and things.
Paul,
Mm-hmm.
Can you hear me?
I can.
Okay. One of the things I wanted to ask, I think you just answered the question about when the new study is going to be ready, because the other one ended at the end of September. Is that correct?
That's right. And the only thing that you'll probably see locally for the coming weeks is I think there may be one more training run locally that has to be done. And those can be done They must be done prior to the site enrolling, but they can be done while we're getting them activated for the continued access protocol.
Okay, and will this mean that everybody across the country will be in it? So everybody across the country has to be ready in order for you to proceed, or is it depends on the local area, or sort of what is that?
Yeah, it'll be institution by institution.
Okay.
So everybody has been already provided with all of the primary documents. And now, there are some differences between whether they use local IRBs or regional IRBs, how quickly their processes go and so on. So now it's really us working with the 25 individual centers, and they'll be active when they're active.
Okay. All right, that's really helpful. And tell me, they're going to be, is it DCD hearts comparing with normal hearts, or what is the comparison group? What is that group going to be?
Sure. So the original study was a comparison of DCD hearts preserved on OCS versus standard preservation of hearts that were not DCD. So just everyday average.
Yes or not?
Everyday average DBD recovered heart on ice. The current study, the one we're about to start, is a single arm DCD on OCS only.
Okay.
And this is really to continue to develop competencies by these sites, to continue to develop data for FDA should they wish to have it while they're evaluating the original data set.
Okay. Did I hear you correctly then that 92 hearts, DCD hearts, have been recovered across the country and put on OCS device?
Yeah, so there were 90 DCD hearts associated with the heart study protocol. And there've been, I think, 2 that were compassionate use. And then there have been 11 that were put on the device, assessed, and declined for transplantation.
Okay. And how far out have you been able to collect data as far as the outcomes of those that have had transplanted the hearts?
Sure. So the primary endpoint is 6-month survival, and only about 20 have reached that point. The final 30-day survivals are coming in to our database now.
Okay.
And then we're going to follow these patients. The DCD patients will be followed through the institution up to 12 months. And then we're going to follow these patients out to 5 years, but we're going to be using data from, SRTR.
Okay. Last question I had is, how long are these hearts being, what is kind of the maximum, I should say, that these hearts will stay on the OCS device? For example, if we're in New England, can you go to Michigan, Colorado? How far can you go, and how long can you use this heart on it for DCD on your device?
Sure. So if I'm not mistaken, in the DCD study, the longest warm perfusion time on OCS, I think, was about 7.5 hours. I think it was something like 450 minutes or something. That's perfusion time. That one had both a longish transport time and a complex recipient operation. So actually the system and the heart sat in the recipient OR for a couple of hours waiting for the implant team to be ready. The answer to your distance question is yes. The Boston groups, I think, have gone down to Pennsylvania. I think they went down and I say poached, recovered an organ from North Carolina. The group from Duke goes to Texas and Florida and Michigan and Minnesota. And so you can do quite long distances.
Okay.
The average, I think, in the study, this particular study, is going to be, again, around 4.5 hours of perfusion time. And it seems like in terms of miles, the range is, I've seen a lot in the 700, 800 mile range. I don't know what the actual mean is going to end up. In our original expand study, there were procurements from Seattle well into Alaska. So there was, well in excess of 1,000 miles.
Okay, great. Other people have questions for Paul? Paul, this has been absolutely fabulous. I've heard a lot of discussions. I've participated in some DCD heart recoveries. I think one of the things that, because I've been involved with the donor, I've never really had what I felt like was a good tutorial on exactly everything about the machine. And this has been extremely helpful. As a nurse, I want to know what all the information is about, where I get it, and what it means if subline is straight, not squiggly, that sort of thing. And you've really helped to answer those questions. I feel like when your team were to come on site, I would know what they were doing, so I wouldn't even have to pay attention, so to speak. I could just focus on my own and really know what's going on. So this is really helpful. The other piece that you brought up that I've not heard, I've heard a lot about lactate, but not the arterial and venous comparison, which was new information to me. It makes sense, but it's new information to me.
Well, good. I'm glad it was helpful.
Okay.
Thank you so much, Paul, Karen, the Alliance. Thank you.
My pleasure.
Really informative.
Great.
Paul, do you mind if people contact you if they have a question?
Oh, it's fine. You've got my email address. Just share it with the group. You're welcome to do so.
I will do that.
Sure.
Okay. Any last questions, anybody? Okay. Thank you, everyone. Have a good day.
All right. Take care.
Thanks,
Everybody.
everyone.
Stay
Take care.
Okay. All right. Talk to you next month. Bye-bye.